So we're going to talk about effects of depression on cognition, quality of life, and care partners. I don't have much to disclose. I do have a grant from the Northwestern Memorial Foundation. I will be talking and using some names of questionnaires and some tests, and that's because there are no generic versions of them, but I don't have any financial interest, and no one in my family does either. All right, goals and objectives. We're going to look at what are some of the cognitive changes associated with depression. We're going to identify the impact of depression on quality of life with people with dementia. And finally, we'll describe the impact of depression on care partners. So, quick review of dementia. We're going to start with a case study. This is not the real name of the person. So we've got Elsie Larson. She's 82 years old, right-handed, married, Caucasian female, 16 years of education, a bachelor's in teaching. She retired from teaching 17 years ago. Since she was about 70, her husband, Don, has noticed a gradual decline in memory. So note that gradual decline in memory. He wondered if it was a mistake that she had stopped teaching at 65. And now he's frustrated because she stays home during the day. She resists his efforts to get together with friends. Elsie does not think there is a problem, also a very important point, and she's actually angry that Mr. Larson is insisting that she see a doctor, probably a scenario you all have experienced. What about poor Mr. Larson? In Mr. Larson's case, I mean, these are supposed to be the golden years, right? The husband is identifying a change in behavior that is concerning to him. There is a decline in memory. Mrs. Larson feels overwhelmed at the thought of going out for dinner. She prefers to stay at home, and previously she liked social activities. She cooked holiday meals. She had her children, her grandchildren over. So a really big change. So let's just review dementia the way I look at it. Two criteria are being met. One is there's impaired neuropsychological testing if you do have formal testing. And we actually have a specific definition, cognitive performance 1.5 standard deviations below age and where necessary education norms. And then impaired activities of daily living. So in other words, the activities in order to run a household are impaired. We at Northwestern, we use the Lawton for instrumental activities. We use the CATS for activities of daily living. I just point this out because often people kind of lump these together as activities of daily living. And really, the instrumental ones, they're the ones for running a household. We put a lot of weight in. Can they take care of their medication, their finances, transportation? And then the CATS, the activities of daily living, are taking care of their body. So like bathing, the way Dr. Cotton was referring to it. And today I'm mostly going to be talking in terms of Alzheimer's disease. So some of the things I say will apply more to that rather than frontal temporal dementia or one of the others. So certainly if you want me to talk about those during the panel discussion, let me know. But, Alzheimer's, look at this, 65% of people with a dementia have Alzheimer's. Another 10% have Alzheimer's with vascular disease. Another 5% have Alzheimer's plus Lewy bodies. So it is definitely the one that is on our radar and the one that we see most frequently. What about depression? Look at this. Scary. Stroke. 47% of people with stroke have depression. 42% of cancer patients. 45% of people with a heart attack. Parkinson's disease, 39%. Alzheimer's, dementia, 40%. So it's something that should be on our radar. But here's the problem. To this day, the population, us boomers who are getting older, when I mention depression, what do they think of? It's a moral weakness. It's a weakness of character. Pull yourself up by your bootstraps. I don't have depression. What do you mean depression? So it's really hard to even check for depression when you ask them about it. It's still seen as something that is a weakness, that it shouldn't be happening. As Dr. Olson said, the DSM, the Diagnostic Statistical Manual, is what we use for diagnosing a depression. You have to have 5 or more of the following. You have to have at least depressed mood or the lack of interest. Easy way to remember it, an old mnemonic, SIG-E CAPS. SIG-E CAPS omits depressed mood, but it's depression, so you can remember the depressed mood part. But here is an easy way to remember it: sleep, interest, guilt, energy, concentration, which is our cognitive that we'll talk about, appetite, psychomotor, and suicide. So SIG-E CAPS, remember that, and you remember basically the DSM definition of it. What's a good way of screening for it? Well, in the office and in Epic, and I know a lot of the hospitals are using Epic as electronic medical record. They either use the PHQ-2 or the HULI, which is very similar. 2 questions. If someone is positive on even one of the questions, then they either go to a PHQ-9, or we tend to use the geriatric depression scale, 15 item, which, fun fact, was actually normed in young North Dakotans originally in their 20s, and now is often used in hospital settings in younger folks as well, because it omits a few things that the Beck Depression Inventory, which is one of the standard depression inventories used, it omits libido, it omits appetite, and it omits sleep, which in our geriatric population and in our hospitalized population is often, caused by other problems, not just depression. So I like the GDS. It's, I think, a more purer picture of depression. Now, what about depression and dementia? We know it can be comorbid, and Dr. Olson talked about that. And one of the questions we always have is, as he was mentioning, could depression be the first sign of dementia? So when I hear that someone has depression, the first thing I ask them is, have you always had depression, or have you had depression before? But if it's adult onset depression, yeah, I got it when I was in my late 50s or something like that, then that makes me wonder, could it actually be one of the first symptoms that we're seeing with depression? We've seen similar things, for example, in Parkinson's disease. Anxiety can predate any of the motor symptoms by quite a few years. Dream enactment by some 13 years can predate Parkinson's disease. So with dementia, we wonder, is depression possibly one of the first symptoms? So how do you distinguish depression from dementia? So people with depression have difficulty concentrating, retrieval memory problems. So this is very important. People with depression don't forget. They have trouble remembering. So what did you have for dinner a few nights ago? No idea. It looks like forgetting. But if somebody gives them multiple choice, did you have walleye? Did you have turkey? Did you have, and so on, then they'll remember it. So they have trouble remembering it. Reminders help. Trouble in the real world is if you don't remember something, no one's going to come up to you and give you a multiple choice and say which one of these, is true. So it can look like forgetting in the real world, but technically when we do neuropsychological testing, if it's depression, we're going to see a retrieval memory problem, meaning if we give them a recognition paradigm where they can choose, more often than not, they will choose correctly. With depression, you get more of a rapid decline in mental functioning. People with depression notice their problems. Usually they're not disoriented, and usually motor skills are fine. What about dementia? It surprises me when I see someone with Alzheimer's, moderate Alzheimer's, and we test their attention concentration. Usually we use digits forwards and backwards. So if I say 3, 2, 1, you got to say, so 3, 2, 1, 1, 2, 3. We do things like that. Their attention concentration is fantastic, no problem, and yet their memory is terrible. They're forgetting. The other thing is, like we saw in Elsie in my case study, it's a gradual progression of symptoms over time. It's not a rapid decline like you might see in depression. You might see a rapid decline if they have a urinary tract infection, something like that. But in general, when you look at the history, you talk to family, the memory gradually got worse over time. They have lack of insight. And this is really frustrating to families because families think, oh, they're denying it. They're just denying it. They're denying that they're having problems. No, they're not denying it. It's actually damage to the brain and they are not aware. Now, in the moment, they might say, oh, you're right. I forgot this. You're right. But overall, they have no idea that there's a problem. Very frustrating for the family. And they can have this thing called a delusional misidentification syndrome. Capgras is when you think someone with you looks like the same person. This looks like my spouse, same name, but it really isn't, because my spouse will be home in about 15 minutes. Actual case that I had with somebody, and actually talked with her about it, and she was not bothered by the fact that this person looked like her spouse, but her spouse was going to come back a little bit later. It was really interesting. Now, how else does it play out? I want to go home, even though the person's in their home of 40 years. I want to go home, and so they'll wander. So you'll see that misidentification syndrome. You will not see it where we say they're not disoriented. You will not see it in depression. And then sundowning. Sundowning is something we don't understand well, but it's where cognitive problems become a lot worse in the evening. So if you look at what are the diagnostic criteria for depression in general compared to depression in people with Alzheimer's type dementia, and I bold-faced the two that are different down here, you have a greater chance of seeing irritability and social isolation or withdrawal. So often, and this can happen in the hospital, you've got someone who's really irritable. So what are you thinking? Oh, they're agitated or something like that. No, they might be depressed. They might just be depressed, or the social isolation. So it does not always present the way we think of depression. So you have to be careful about that. One of the ways you can further look into is there depression present in dementia or not is the Cornell scale for depression and dementia. This was developed by Dr. Alexopoulos. It's 19 questions. It is a formal interview done by a clinician. You interview the patient, you interview the caregiver, and it helps to differentiate that. And it's also helpful if you're treating the depression and you want to see, is there any change in it? But as you can see here, it goes into these 5 categories here. So that's one scale you can use. Now, the geriatric depression scale, you can still use in dementia. Depression in older adults. So 15 to 27% of individuals older than 65 living in the community have depressive symptoms, maybe not depression, but depressive symptoms. Look for crying, tearfulness, hopelessness, self-deprecating comments, agitation. So with some of the tests we give, and we have psychometrists who are technicians who give our tests, and their observations are so important, because sometimes we'll give a test like the Hopkins verbal learning test. It's a bunch of words they have to remember, and people will get tearful when they're not able to remember the words, but not everybody does. So we want to know about that, or they'll really be very critical about themselves. And so that's a red flag that maybe they have depression. Just like Dr. Olson said, the questionnaires we use, like the geriatric depression scale, it really depends on the patient answering the questions accurately. And sometimes if someone has no insight, then you have to question how accurate that is. But if you look at how they're acting under a stressful situation, like testing, that can be helpful as well. Prevalence in women over 60 can be twice that of men of the same age. And if you got old white guys like myself, we account for 81% of all suicides annually. So that should be on your radar as well. Depression also amplifies cognitive deficits. So that's an important fact, because if I have someone, they have Alzheimer's, they're having a lot of problems with their memory, for example, and they're depressed, we're going to treat that depression, because depression doesn't cause forgetting. In Alzheimer's, you see forgetting, but if I have memory problem related to depression on top of the memory problem related with Alzheimer's, my memory is going to be a lot worse. Let's treat the depression. Maybe we can at least modestly improve the memory. So it can definitely amplify cognitive deficits. And to make things worse, you can have comorbid anxiety with depression. So in elderly patients with depression and in elderly patients with dementia, you can also have anxiety. Anxiety hits us at the level of attention concentration. So going back to what I was saying earlier, straight Alzheimer's disease, attention concentration is going to be fine. Anxiety, add that to it, you're going to have some problems with attention concentration. And in fact, your depression can cause such a problem in cognition that you can have a phenomenon that used to be called pseudodementia. 1961, Dr. Kilo described it, and it's basically where someone, because of depression, a severe depression, looks like they have a dementia, but if you treat the depression, you can get them back to baseline. Now, they might be at risk for a depression, for a dementia down the road, but at least temporarily, you're turning the clock back. Nowadays, we don't use that term. We instead talk about modifiable and reversible factors. And we look at things beyond just depression. Depression is one of the things we look at. But for example, a low vitamin B12, that's going to cause problems. Thyroid not working properly. It's kind of like round up the usual suspects, of which depression is one of them, and see if we can maybe improve things at least temporarily. So when we think depression, there are physical signs we see: blunted affect, psychomotor slowing. It affects sleep. And what happens when you don't get good sleep, good quality sleep? Your attention concentration isn't very good. You might be kind of irritable. Decreased appetite, that's a huge one in the elderly. We look at their BMI. If they're too thin, that's a risk for increased risk for morbidity and mortality. We don't want them too thin. Increased pain sensitivity. They will feel pain more if they're depressed. And what does that mean? That means their cognition's not going to be very good because they're reacting to their pain. And also diminished visual contrast perception. I've got a picture coming up on that one. Cognitive symptoms, the ones that stand out, are executive dysfunction, which I'll define in a minute, and retrieval memory problems. So here's what we see in general with depression. Simple attention, typically spared, unless you've got the anxiety on board as well. Executive functioning, impaired. Psychomotor speed tends to be slowed. Doesn't affect intelligence, but let's say I'm trying to figure something out. It's going to take me longer to do that. Language is technically spared, but I'm going to give you an example of how it can look like it's impaired. Memory, you have impaired free recall. So going back to our word list, and you all might be familiar with the MOCA, the Montreal Cognitive Assessment, where you get 5 words, you repeat them a second time, and then a few minutes later, remember the words, and we see how many words somebody got. Maybe they get 3 out of 5, and then you give them a category cue. One of the words was parts of the body, and maybe that's enough for them to say, oh, it was face, or they still don't remember, and then you give them a multiple choice. Was it hand? Was it foot? Was it face? It was face. So they're able to recognize it, but they might not recall it. So it's always very important when you're testing memory, even if the test you're giving doesn't have some sort of a multiple choice paradigm, you can what we call test the limits. Once you've given the test, like the mini mental status exam, Folstein's MMSE, if you give that as 3 words, there's no multiple choice or anything. When you're done with the test and you've got a score, you can test the limits by going back. And if it's apple, table, penny, say, well, one of them was a fruit. See if that helps them remember. Or you can say, well, was it a banana? Was it an apple? And so on. So you can test that. And then visual spatial. So what's executive functioning? Front part of the brain. It's your frontal lobes, your prefrontal lobes. It's the things that basically run the rest of the brain. It's your concentration. It's your focus. It's your thinking speed, mental flexibility, multitasking, planning, organizing, sequencing, problem solving, and so on. And we'll talk about apathy because that's part of executive functioning. But apathy is actually separate from depression. You can have motivational problems, but apathy is its own separate problem. So that's executive functioning. And those are things that can be affected by depression, with the exception of simple attention, concentration. In dementia is going to be okay, but it's going to be impaired in depression. Cognitive changes. Technically, language is spared, but one of the things I noticed with people is sometimes they'll complain of word finding. And the reason for that is slowed processing. So in the real world, yes, they're having trouble coming up with a word, but it's technically not a language problem. It's actually the slowed processing due to executive functioning. And so you want to treat that appropriately, namely treat the slowness, which is secondary to the depression. And then what about memory? So memory is made up of two things, right? First, you have to learn it, and then there's the memory, the persistence of the learning. So again, going back to the Montreal cognitive assessment, you say the words and the person has to repeat them. You do it twice. So that's kind of a learning paradigm. And then the memory is tell me the words later. And again, direct recall versus recognition. Memory, as far as depression goes, they'll learn the information, but their immediate recall might be terrible, might be even zero. It's only when you give them some sort of a recognition paradigm that you're going to really find out were they able to remember it or not. Again, in the real world, though, it can look like forgetting because people don't go around giving you cues if you don't remember something or a multiple choice. It can also look impaired because the person's hard of hearing, and so they didn't get some of those words, so the learning never happened, so it's going to look like forgetting. So you have to be very careful when you're testing for memory because other factors can interfere with the memory. But if it's memory due to depression, and if there aren't other factors that have interfered, you give them some sort of a reminder, it should help. Here's the scary thing with depression. It can affect contrast sensitivity. So here's a car. This is a British picture. It seems like the British pictures, they're always doing things on vision. Anyways, here's a car, and I'm not depressed. Here I'm depressed, and you can barely see the headlights. And this is the person who's driving home at the same time you're driving home. That's kind of scary, right? So it can affect that. It can also affect the ability to discriminate colors. So I put that under visual spatial. Yes, it's physical, but it's also visual spatial, which is right side of the brain. Now I want to, so remember, depression is not associated with forgetting. Depression is associated with remembering or retrieval memory problems. I want to talk now about apathy. And the reason apathy is important is, number one, it's separate, although people think of it as the same as a part of depression because of the problems with motivation, but it's actually separate, and it drives caregivers and family nuts. I hear this all the time. Doctor, he just sits in front of the TV all day. And that's bad on a number of levels. It's bad, as it says here, in daily functioning. There's a lack of stimulation. What helps us either prevent or hopefully delay dementias? We know social stimulation, intellectual stimulation. Treatment adherence. Well, we'll give them their medication later. He fell asleep again. They're not exercising. Reduced quality of life, both for the patient and for the caregiver, and just caregiver distress, because that emotional connection is not there. He's in front of the TV all day. He's just not communicating. Is apathy common? Well, look at it in Alzheimer's, about 70%, frontal temporal dementia. You're getting into the 90s. Dementia with Lewy body, like Robin Williams had that one, you're about 90. This Parkinson's disease, I don't believe this one because I would say it's at least up here in my population. I see apathy quite a bit in Parkinson's disease. So they do share some things. What does apathy and depression have in common? Diminished interest, psychomotor slowing, fatigue, and sleeping a lot. So it's very common to fall asleep in the chair. But there are things that are unique to each of them. Unique to depression is more state of unease and dissatisfaction. Unique to apathy is kind of this diminished emotional responsivity, and I'll give you an example in a minute. They have decreased goal-oriented thought. You see suicidal ideation with depression. You don't really see it with apathy. They're too apathetic. Self-criticism, guilt, pessimism, hopelessness, and a sleep disturbance. Here you've got low social engagement, diminished initiation, poor persistence. So apathy can range from being mild And we see this particularly if we have somebody with early onset or young onset Alzheimer's where they're still working. You have some maybe mild inefficiencies at getting things done at work or at home. I've had patients who they come in after a few years, they got fired from their job, usually unfortunately 2 or 3 years ago. I had one gentleman, he was a manager, used to be able to take care of 5 projects at a time, was down to 2 or 3, got fired for being lazy. He wasn't lazy. He had the disease of apathy. And then you can have severe apathy. So there they can't initiate or sustain a goal-directed behavior. We had a gentleman and his wife told us he decided to paint the garage. And we're like, fantastic. This is a guy who was in front of the TV. He went and he got the paint. He set up everything in the garage. You know, he put down tarps and everything. He painted one wall. That was 3 weeks ago. He was able to initiate the behavior. In his case, he wasn't able to sustain the behavior and finish it. And so what we did was we got his son to say, Dad, you know, I love the way you paint. Apparently, he really was a good painter. I want to learn how to do, can we do this together? So with someone else, he could do it and did a great job, but he couldn't do it on his own. But here's the other problem. There's diminished emotional responsivity. In other words, you do a great job doing something. What do you say? Fantastic. I did this. This is the best job I've ever done. They have no response to it. So they're not getting that positive reinforcement of a job well done. And that also can drive families nuts because there's something terrible that happens, a personal loss, someone passes away and the patient reacts emotionally indifferent. They might even be euphoric, no reaction at all. And with a favorable event like painting the garage, he couldn't really care less. Yeah, he did it. That's great. But it's kind of like whatever. So demoralization versus depression. That's something else we see. Demoralization is your patient who says to you all of a sudden, I just wish I wouldn't wake up in the morning. And you're like, okay, we got to check out for suicide here. So we're going to give the Columbia or the ASQ or something. But with demoralization, it's a little bit different. Here, there's a loss of sense of efficacy, incompetence. There's a helplessness. They focus more on the external. They might have pain. And if the pain is controlled better, they actually improve. So increases as physical symptoms increase, decreases as physical symptoms are better. They are responsive to self-compassion, spiritual support. They're not helped by antidepressant medication. They have a passive death wish, desire for hastened death. I wish I could join my husband, that sort of thing. But they're not actively suicidal. Whereas with depression, it's going to be more like life has never had any meaning, or I'm being punished for the evil things I did, or a perception that I'm ruining other people's lives, and some suicidal ideation rather than just this passive wish that I wish I wasn't around anymore. So that's important. Now, demoralization requires that you have insight into something going on. So in Alzheimer's disease, you're not going to see demoralization. So what about quality of life? And this one's actually pretty brief because what we know is you'd think that as the dementia got worse, the quality of life would get worse. But why doesn't it? It doesn't because I have no insight that I've got a dementia. So I'm getting worse, but I'm not really noticing it. However, if I have depression, the research shows that I will have poorer quality of life. So dementia doesn't cause a decrease in quality of life, but the depression and the cognitive impairment that goes with it can decrease quality of life. 2 interesting studies. One is by Ho in 2010, found a decrease in quality of life was associated with increase in depressive symptoms in individuals with dementia living in a facility. And then Voros took it out to the community. What about the community? So similar relationship with community dwelling individuals, in addition to a close relationship with depression and cognitive impairment, as it relates to pseudo-dementia that we talked about earlier, you also see a decreased quality of life. So early recognition of depressive symptoms using whatever measures you're using, whether it's the PHQ-2, the Hooley, geriatric depression scale, and then appropriate treatment by seeing a specialist like Dr. Olson. And that's one of the challenges, is trying to find someone who does specialize in geriatric psychiatry, because they are few and far between. Even in our Chicago metro area, I've got two in the area. I'm in the western suburbs. I've only got two in this whole area, and we have several health systems out here represented, and we're the only ones that have two. So very, very hard to find, but very important. Quality of life in people with dementia in care homes. What Dr. Ho used was a measure called the Quality of Life Alzheimer's Disease. And that one has 13 questions. It rates life situations as poor, fair, good, excellent. You give it both to the patient and to the caregiver. And you can use the Cornell that I referred to earlier, and the Hooley or PHQ-2. So you do want to be aware of that can be a problem. What about care partners? How do care partners end up becoming caregivers? So how do you support them? What happens with depression? And I've been alluding to that. Like I said, the person sitting in the chair all day, that's stressful. But on top of that, you can see depression in the caregivers as well. So depression is not limited to the patient. 20% of family caregivers, that's twice the rate of the general populations. Add a family caregiver of someone with dementia, and it can be as high as 60%. And on top of that, we saw with COVID-19, people started looking at loneliness, which is a feeling of being disconnected from others. And that is also a contributing factor to depression. So we need to be alert, not only in the depression in the patient, because that's going to make them more cognitively compromised, so more difficult to manage, but also in the caregiver. And as Dr. Cotton said, the better prepared, the better educated the caregiver is in managing the problems with the patient, the better the patient does. And we see that all the time. We'll see people with two people with Alzheimer's, exact same Alzheimer's. One is, kind of agitated when they come in. The other one's doing fine. And often it boils down to how well the caregiver is doing. Who are the caregivers? They're mostly relatives, or mostly women. 4 out of 10 caregivers say they had no choice. Women caregivers are almost 6 times as likely to suffer from depression or anxiety, and in general, women's health will suffer. And even though we say, you can't take care of your loved one if you're not taking care of yourself, and they're kind of like, yeah, you're right, but who's going to help me? So depression in caregivers, I thought this was a good quote. Taking care of someone with dementia is a long-term responsibility that can be stressful and may lead to depression among family caregivers. Depression and related behavioral and cognitive changes among caregivers could in turn affect the status and prognosis of the dementia patient. So true. And if we look at Alzheimer's progression, we start off with the cognitive symptoms. So I've got some forgetting and so on. But then when I start to lose my ADLs, so like Dr. Cotton was saying, you're trying to get me in the shower, you're taking my clothes off? Who are you? I don't even know who you are. So you have problems with that. So now you've got some behavioral problems. You're kind of managing this, but when you see incontinence, when you've got a loved one who, despite the fact that you're trying to lock all the doors at night, goes out and starts wandering at night, when they keep you up all night, that's when nursing home placement can occur. So what happened with Elsie? She had no insight into her problem, which include memory. Her instrumental activities of daily living, as you would expect, were pretty much supported by her husband. She did need some help with bathing. These are some other questionnaires we look at. One is symptoms of early dementia 11 questionnaire. She's repetitive, drives the family members nuts. You've asked me that question 3 times today. That's not what you're supposed to say, right? You don't say that. She has difficulty understanding facts when queried. She's not oriented, and she becomes upset when family members correct her. We're going to talk about what to do. And then, as Dr. Olson mentioned, the NPI the neuropsychiatric inventory, very good. I use the questionnaire. It's a shorter version that was developed. So I use that one. And then for caregiver burden, we use a scale called the Zaret. There's a few scales out there. We use the Zaret. We like that one. I'll show it to you in a minute. But again, these are things that can be very, very problematic for the caregiver. So wandering, if they're driving, worried that they're going to get lost or they're going to get into an accident or something like that is very, very concerning, of course. Psychosis, and Dr. Olson went into some of these delusions, the spouse having an affair, the misidentification syndrome I mentioned earlier, hallucinations, which again are typically visual. And I've had exactly the example he gave. I had a woman who got kind of frustrated because she set a table for 6 children and they never spoke, because usually they're only visual hallucinations, and they didn't seem to appreciate the lunch that she set down, but they're not scary. And so one of the ways we manage that is make sure that the person doesn't have sensory deficits. Get them that hearing aid if they'll wear it. Make sure they've got good glasses, and then of course a good physical. So other dementia issues that affect caregivers are the fact that the patient's not aware in Alzheimer's, the fact that they might get up in the middle of the night and wake you up. They might not be eating. They might become agitated. They might be disinhibited. They might say something embarrassing. So one of the ways we measure that is with the Zaret caregiver burden. So this will have, like this was, are you afraid about what the future holds for your relative? And they had endorsed frequently here. There's one about money. Do you feel like you're going to run out of money taking care of your loved one, and so on. And then this is this is a 3-item loneliness scale. The actual original is about 20 items, but this one's a pretty good one. We do this for both the caregiver and for the patient. How often do you feel that you lack companionship? How often do you feel left out? How often do you feel isolated? And they first did some studies in nursing homes and then in the community, and people who are in the clinical range, so 6+, have a greater risk of morbidity and mortality. So why is it so hard for patients to receive care? Well, I don't feel comfortable asking for help. I don't want to lose my privacy, right? You try to get someone to come in for a couple hours a day, and what happens? They fire them. I don't want to lose my dignity. So how do you help patients accept care? One is dignity and routine. If you don't know when you're going to be done with work and get home to the patient, don't give them a time that you can't really keep to. Be very, very specific, be very realistic. Doesn't this look like a lot of us? And then we say, oh, we'll be home by 6 o'clock. Yeah, lucky if you're home by 8. And here's this patient's waiting, so she's frustrated. And then what do you say as the caregiver? I dropped everything to get home, and this is what I get in return? Choices. So learning that in the beginning you can give choices. As the dementia gets worse, you might give 1 or 2 choices, or you might just say, let's do this tonight. So help them manage their world in a way that they can be successful. The other thing is validate the person's beliefs, their feelings. We call that get into the patient's world. And in this example, she was frustrated because Bob had not come to visit, and she had been waiting for Bob all day. Well, Bob died 10 years ago. There is no reason why you would try to correct her on that. Instead, you would affirm that and say, oh, that's really frustrating that he didn't come, and then you distract. Why don't we look at this scrapbook? I know you said you were going to update it. Let's take a look at that. And that is appropriate. And doing things together, and Dr. Cotton was alluding to things like that, so mutual enjoyment. So here, this is like a reminiscence therapy. They're looking at old pictures. And like Dr. Cotton said, it doesn't matter if she's accurate or inaccurate as to who these people are, or what the situation was, as long as they're both enjoying it. That gives a connection to both the caregiver as well as to the patient. And then the old good enough. In other words, if the patient cannot do it perfectly, and as long as they're not hurting themselves, let them do it and celebrate it with them. Do you really think she needs all these towels folded? I don't think so, but he likes doing it. He feels that he's able to contribute something. He does a pretty good job, probably better than I do, with folding them. And you know what? She can unfold them and he'll go fold them all again. And that's giving him dignity. There's also what we call the principle of negotiated risk. That's our one social worker, Debbie Crystal, came up with that. And that's where something might be a little bit of a risky behavior, and you negotiate with the family whether or not it's okay for the patient to do it. And sometimes you take a little bit of a risk. Just a quick example, we had a gentleman with Parkinson's. He wanted to do fly fishing. His Parkinson's also included some problems with balance. So we had to make sure that he always went with somebody. He had a life vest on and everything. Was it risky? Yes. He loved it. We had pictures of him just grinning from ear to ear. So sometimes you have to do something a little risky. And you want to maximize strengths. So if a day program is available, something like that can be super helpful. Here's some pictures of people doing well, like pet therapy. And llamas are great if people, especially are from a rural area, are used to having horses, cows, and so on. And again, you've got the social interaction here. You've got some of the intellectual, stimulation. Very, very important. So why is it hard for caregivers to accept help? Same list. I don't want to lose my dignity. I don't want to lose my privacy. This is a wonderful resource. Look up Wendy Lustbader, University of Washington. The gist of it is, as a caregiver, when you start to feel resentment, you're giving too much. And she talks about things that you can do. You've got to stay healthy. But this just fantastic. She's a fantastic social worker. There's a film you can get. Unfortunately, it's not cheap and you got to get it from this Terra Nova, but we bought it for our library for our patients here. It's just fantastic. So caregiving, you've got to take stock. As Dr. Cotton said, look at the needs of the patient. What do they want for personal care? What do they need medically, and so forth? Decide what needs you can or would like to meet on your own. Determine what needs can or must be met by others. So sometimes, people say, oh, call me if you need some help. And they mean that, but they're also not around. So sometimes you can actually get help from people from church or other friends. Identify family and friends. Establish the need for outside professional help when you need it. And that's where social work can be really helpful. We have 3 dedicated social workers here in our center, and they will often help patients and families determine care that's needed, what can they afford, what are reputable organizations. And then support groups. Love support groups. I have learned more from support groups when I attend those than I have from book learning or anything. And it's great for patients and it's great for our caregivers. So we usually will have the caregivers in one group and we'll have the patients in another group. The purpose of the group, of course, is emotional support. We use a facilitator model. So the experts are the caregivers there. We try not to be the experts, but they get networking, they get information. Occasionally we have a speaker coming in. And then, as far as the group audience goes, like I said, we have caregiver groups and we have patient groups. And now we've got both virtual and in person. Of course, we like the in-person better because people get their relationships, better that way. Okay. And then the rationale behind a support group, of course, is feeling safe, realizing that you're not the only person with this problem, place that you can express feelings, a place to find hope, empathy. And this one is super important. You end up helping other people. And that's healing. That makes you feel good as well, because sometimes it feels like everything is out of control. So what about Mr. Larson? So he's embarking on a long, challenging journey of caregiving. Not correcting Mrs. Larson when she thinks her brother is alive is hard, but he's able to do it. He told her he doesn't have enough to do, so he's going to do the driving. She likes that. He gets out for coffee. Friday nights, his daughter brings over the grandkids so he can go bowling, and he comes to the doctor. So quality of life, family and friends, important for family and friends to take care of themselves, develop a network of helpers, a designated person to eventually help make decisions is really important, both for medical. So power of attorney for healthcare. I print those off like candy. I give them to everybody. I make them fill them out. And then power of attorney for finances. Sometimes you need an attorney for that. Sometimes you don't. So we talked about the cognitive changes associated with depression, the impact of depression on quality of life, and the impact on care partners.